My name is Leslie Ansell. I'm a doctoral student at Auckland University of Technology in New Zealand, and I'm a midwife. I became interested in the management of shoulder dystocia when I was involved with a very severe shoulder dystocia, and the internal manoeuvres, Rubens 2, wood screw and reverse wood screw manoeuvre, simply didn't work. The baby was eventually delivered following removal of the posterior arm. She had a fractured humerus and required full resuscitation. Following that really traumatic experience, I thought there's got to be a better way. I kept thinking about removal of the posterior arm and why go past the axilla when that must be a tangible part of the baby to be able to get hold of. I began to talk to other practitioners, and I realised that some practitioners had probably used axillary traction by accident. So that began the start of my research. I also began to use axillary traction in my own practice, and other practitioners watched me and they began to use it. Suddenly, it had crept into practice and we realised that we had a good deal of anecdotal success. Axillary traction, therefore, became the topic of my master's and subsequent doctoral studies. Once the head is born, ease the head up gently with the non-dominant hand and slide the dominant hand, either right or left, along the fetal neck and onto the posterior shoulder. Keeping the fetal arm firmly against the body, apply traction directly through the axilla to follow the sacral curve. That traction may need to be very significant, but keep going. The posterior shoulder will deliver over the perineum and the anterior shoulder will then slip under the symphysis pubis. If both shoulders fail to enter the pelvic cavity and they remain above the pelvic brim, often rotation is required. In the same way as before, slide a hand down the neck and onto the back of the shoulder and push that shoulder towards the fetal chest. This should cause the opposite shoulder to drop into the posterior aspect of the pelvis. Re-enter the pelvis and apply axillary traction as before to the posterior shoulder. In some cases, this may need to be repeated. In 2009, in the midst of the master's study, and although not completed, axillary traction was discussed at the obstetric clinical practice group as a way of resolving shoulder dystocia and was accepted as part of the shoulder dystocia guideline. It's been widely used since then in a population with a high rate of diabetes, obesity and comorbidities, with a great deal of anecdotal success. Subsequently, I began a retrospective study to compare the effectiveness of axillary traction with internal rotational manoeuvres and delivery of the posterior arm. The main findings were that axillary traction has a statistically significant success rate of 95.8%. So it's recommended that when an internal manoeuvre is required, axillary traction should be used first.